The Evidence for Change program was written into the original Clark Northwest Coast bid as part of the capacity building. At that point, it was called Team CPD, but it's based on some assumptions about that people would want to make changes in their practice. So the people in the NHS and in social care want to make changes in their practice. They might not have the evidence that they wanted to use it to make those changes, but that actually, if we had them working in teams, it would be stronger and it would be easier for them to identify the evidence they needed and make those changes in health and social care.
Good morning, everybody. My name is Tahir Qasim. I am the one of the team members and the lead for this project. And the project was created to improve bowel cancer screening uptake in the Black, Asian, and minority ethnic communities in three neighbourhoods in Liverpool, where many of the we call BAME population reside. The partners who worked, we are a big team. The partners who work within this project are people from the public health within the city council, from BAME communities, Liverpool Clinical Commissioning Group, the NHS England, Cancer Research UK, Liverpool Community Health, and the clerk, of course, who helped us, being here today. Within the next 20 minutes, you will hear from different speakers who are going to say something, and the whole project was trying to tackle health inequalities by seeking to improve bowel cancer screening among BAME communities. And we divided the task, and I thought that it would be sensible that in phase one, Richard is going to talk about what has happened in that phase. And then Jahanara is going to talk about the involvement of the panel advisory group, which is the only advisory group within the four teams. This is the way how we did it in Liverpool. And then Julie is going to talk about what happened in phase two. And then finally, I will come and say a few words about where do we go from here, and what our ideas in the next phase, which is the third phase. So I will hand you now to Richard.
Thank you, Tahir. I feel underdressed. The first time I've ever seen Tahir in a tie. I could have put my Asda suit on if I'd have known. So, now I'm Richard Jones, by the way. I'm a public health epidemiologist in Liverpool City Council. And I suppose I kicked off this whole process by doing some analysis around some bowel screening. I did it as a favour for someone who was doing a dissertation, which I'll come on to that later. I had no idea I'd end up in this beautiful setting 18 months later. So why is cancer an issue in Liverpool? Well, I've been in this job for 11 years, and when I started, cardiovascular disease was the biggest killer in the city. Over time, cancer has now replaced cardiovascular disease and kills more people than anyone else in the city. So there are a lot of partners working from various organisations to try and tackle this issue. For this particular project, we are looking at bowel cancer. There are around 200 new cases of bowel cancer to people who are aged under 75 each year. And Liverpool has some of the highest rates of bowel cancer incidence, and it's the third highest of the core cities, and there are 8 core cities nationally. There are also 60 premature deaths, so 60 of our residents die before the age of 75 from bowel cancer. And this is the 12th highest male rate in the country, so it's a particular issue for males, though the female rate is also very high. And it's the second highest premature mortality rate behind Manchester. However, it's not all doom and gloom, because survival rates are actually quite good. 3/4 of patients who are diagnosed with bowel cancer will be alive after a year, and half will be alive after 5 years. So these days, if you get bowel cancer, it's not necessarily a death sentence. Now, bowel cancer is one of those disease areas which is in the preventable group. So it's a public health issue in that if you can catch bowel cancer earlier, the sooner you diagnose it, the sooner it can be treated, the more successful the treatment can be. So screening is an important issue. Now, if you look at this chart here, the target for the national screening programme is 60% uptake. And you can see the red line, which is Liverpool, is considerably below that. So our uptake rate for bowel cancer screening is low. Now, each of the bars is our GP neighbourhoods. Now, those of you who don't know Liverpool, what that chart is showing, that in the more affluent parts of the city, bowel cancer screening uptake is relatively high. And in the more deprived areas, it's low. There's a very good correlation between deprivation and screening uptake. Now, the 3 areas that we're going to be looking at today are those shaded in green. They are Riverside, Kensington, and Picton. Now, these are our communities that have the highest BAME communities living in them. And you can see, although deprivation is a huge factor in uptake, you can see that our our communities with the highest concentrations of ethnic minorities have particularly low rates. So that's the background. Now, about 18 months ago, as I alluded to earlier, someone in our team was doing a dissertation on bowel cancer and bowel cancer screening, and she got hold of a huge data set after much wrangling from the regional hub. And this was 3 years worth of anonymised patient records. Excuse me. And this was 89,000 individual records. And she wanted to look at, what was causing low screening uptake. So one of these indicators that I looked at was ethnicity. Now, an ethnicity field wasn't attached to this data set, so I had to add it in using the 2001 census. So it was to get an approximation of black and minority ethnic communities and attach to their screening records. I can get more technical than this, but everyone will glaze over. But effectively, what the charts are showing, these are 2 charts for Picton neighbourhood, which has the highest concentrations of BAME communities. And those of you who may have heard of Toxteth, that's where Toxteth is based within this community, to give you some context. Now, you can see the red line on the top for uptake. That's the neighbourhood uptake rate for Picton. And the black line is the Liverpool uptake rate. So within this community, it's significantly below Liverpool. But even within Picton itself, as the concentration of ethnic communities increases, the uptake rate goes down. So it does seem to suggest that there is an issue potentially going on of low uptake amongst our BAME communities. And the chart below is the flip side of that. That's the abnormal findings. So where those communities are more concentrated with BAME people, the abnormal results go up. So you could argue, and this is what the purpose of the Clark was, that if we try and do an intervention around bowel screening uptake amongst BAME communities, we might find people with either bowel cancer or with polyps, which are precancerous bowel cancer, and treat them and potentially save lives. So, what we did with this presentation was quite a large presentation. We touted it around the respective partner organisations. Public Health gave us the go-ahead to do this. And we also presented it at Liverpool Community Health and Cancer Research UK. And then we took it to the 3 neighbourhoods in question, and we received mixed results from the GPs present. Some GPs were opposed to screening, were quite hostile and attacked myself on here, not physically but verbally, and they were blaming us for the National Bowel Cancer Screening Programme, which had nothing to do with us. Other GPs in other neighbourhoods were like, yes, there is an issue with BME communities, we've seen it, we need to do something about this, but we've got no money, so go away. And this kind of led us into the Clark process, which Tahir has led. First of all, we wanted to see if there is an issue amongst BME communities. We've only got some, it's not dodgy, but it's questionable evidence. So the process was to see if there is any evidence and then see if we can put something in place to try and improve uptake rates amongst our communities. So that was phase one of the process. And now I'd like to hand over to Johanara, who's going to do the next phase.
Okay. So the slide's been updated? Yes?
Yeah.
Great. Okay. So I will talk about the BAME advisory group, which represents the Black, Asian and minority ethnic communities. And the members of the group were recruited through community organisation and existing networks working with the BAME community in Liverpool. And I think this group is quite... it embraces the diversity of the BAME community, and it just doesn't address it as a definition. And for that reason, we decided as a group to send different members to the workshop at the Evidence for Change, so members can be fully involved in the process and learn about the process as well. And this was shared during the monthly meetings, at the panel advisory group meetings, to see where we are with the intervention, to see some of the challenges that we're faced with, and the way forward. And what we hope to achieve in phase 3 through community engagement is to explore new ideas of how we can work with the BAME community, because there is like a diverse needs in terms of how we work with different ethnic groups. And again, as I said, it can't be addressed just under one single definition as a BAME group. Different groups have different needs. And we have explored ideas around using the possibly using drama to kind of get that message across. So for the key for us in phase 3 is to reach out deep into the community and raise awareness about the intervention and about the awareness of bowel screening. What we have as well, in the panel is a lot of community knowledge and a lot of community intelligence, and we plan to use a lot of that to address some of the challenges that we may be faced and use local solutions to address that. And I think this whole approach really creates a positive environment where you have the BAME panel and also key stakeholders who are key players and will influence change and influence policies to empower individuals within the BAME advisory group and within community. And it's really useful as well for relationship building as well, to gain a better understanding of the complex issues within the community and how we can address that in relation to the uptake of bowel screening. And that's it from me, and Julie will talk more about phase 2. Okay.
Hi, I'm Julie Byrne. I'm a screening and immunisation coordinator, and I work in Public Health England, and we've been involved with this project. Public Health England within Merseyside, or Cheshire and Mersey as our team is, we actually commission and oversee the screening programmes that operate. And I'm the bowel screening lead and also the Liverpool lead, which is why I ended up working on this. Looking through, what I'm going to talk about is how we looked at the problem and how we thought about getting some information together and how we worked with the Clark within that. Obviously, it was the City Council that were approached through Clark in order to take part in the project. When Tahir started working on that, and obviously the information from Richard, it became apparent there was an awful lot of stuff that we needed to do in quite a short time period. I think one of the major things just to get things rolling was about getting approval from senior managers within the City Council, within NHS England and Public Health England and the CCGs, getting everybody involved. And it was quite a task, I think, to do that. I think I would say Tahir did visit a lot of people in order to, get it rolling and get it moving on. A proposal was drawn up and submitted, and we were lucky enough to be accepted. And I said, I think particularly Tahir and the City Council were really keen to make sure that the whole health economy was engaged in this. This isn't a problem that we can tackle just as one organisation. Everybody really does need to work together. I think that's been quite a benefit of this project, that we have had really good representation. Obviously CR UK have been heavily involved, as well as all the NHS and Liverpool Community Health, all the NHS organisations, and we've managed to get people from other partners involved. It's been quite good. And obviously TAR has done a lot of work around the BME advisory panel as well. So looking at the process and learning, we started to look at evidence and what was available to actually back up the stuff that Richard had done. It was, I'd say, we found different levels of evidence. Some of the evidence seemed to be pretty high level and we thought was reputable. There were other bits that actually the evidence was poor when we started looking at the papers. But what we wanted to do was look at what had been successful in other areas and use that evidence to actually influence the project that we would come up with. And obviously, look at this slide, you can see how looking at the different levels of learning that happened. Obviously, on an individual level, as people went away, people had to obviously understand around making sure they were planning things appropriately, work balance. That was quite a challenge for a lot of people. Some members of the team were able to contribute more time-wise than others maybe, which again, we managed, but it was a time challenge, I'd say. It didn't always feel equitable within the team, what some people did compared to others. And obviously going out and getting that field work and research was quite useful. As a team, it did help us work together a lot. It was really good the way they set meetings up, email communication was there. I wasn't personally able to attend a lot of the team meetings, so the email communication was really valuable for me. The other thing is, obviously, when we started looking at the problems, we did realise that one of the challenges was around ethnicity, data and language, what we had available. The project that we'd originally looked at was looking at targeting specific groups, and we thought about very specific communities. But as we started looking further into that, we realised that there was very little data to back up around ethnicity, data recording, and most of that comes from GP practices. It was sketchy. Some GPs were quite good at it, others were poor. It was really quite difficult, and because of that problem, in the end, we had to pretty much change the focus of the project. So what that moved from the idea of the original project was to target those groups and get specific literature, work with Liverpool Community Health to go in and target those areas. In the end, actually, and Tahe will talk more about this, what we ended up doing was actually part of the project became about getting that ethnicity data to make sure that what we were doing was appropriate for those communities. And what we did find by looking at census data, some of that was possibly a little out of date, in as much that through working with Liverpool Community Health and the social inclusion team, they said what was relevant when that was collected had moved on, communities had moved. So where we once had quite a large Polish population, that community had started dispersing around the city and they weren't necessarily living in that same area. That's happened over a few years and it hadn't yet been picked up by census data. So on that on the ground information actually made quite a difference to what we were able to do. So from that we were quite lucky to actually with some of the evidence we'd looked at, and we were lucky that we knew somebody who worked in another area and had made contacts. We were actually able to have a teleconference with Tower Hamlets in London, who'd done quite a lot of work, and they'd evidenced a lot of their work. So we were able to have a teleconference with them and work out from them what they'd done, what worked well within their community. So we were able to learn from other areas' experiences. That meant that we did actually put patient profiling back on, because they sort of explained how important it was. So that became into our project. We managed to get the CCG to agree that, and the CCG, for people who don't know, that's the Clinical Commissioning Group, and that's a body of GPs, and actually the idea of that is that they understand their own patients, their population. It's about having a very local level to best suit their population and their patient needs. So they were really keen to get involved with that. And the CCG agreed that they would do a pilot alert about getting ethnicity and language in neighbourhoods. So they'd work with the GPs in order to make sure they started to collect that information. What we did also find is that if we get this data, it can help benefit other programmes that we're running. So in Liverpool, they're running a healthy lung programme, which is starting to identify patients who may be smoking and other risk factors in order to help improve and to identify problems early on with that. We hope obviously it would help with cervical screening, which is another of our cancer screening programmes, which we tend to find that uptake within BAME communities is a lot lower. So by having that data, it can help us to influence about what information we need to give, how we need to approach the areas. And again, our diabetic eye screening programme and diabetes in general. So all of this information actually is quite rich, and it will help us to inform a lot of the other programmes and around other health needs that are in the city. We are attending the next bowel cancer screening programme board, and obviously that's you presented that a while ago, Richard, originally, didn't you? Your original data was presented. So obviously this will be a nice follow-up to be able to say we presented this about 12 months ago. So a little bit further on, be able to say this is where we're at, this is what we did with that data, and hopefully because we're Cheshire and Merseyside, that if what we do here in Liverpool shows to be beneficial again, we can look and see how that might work across Merseyside. Not as high BMA communities across other areas, however it's still relevant, so we might, again, another learning point to move forward. And then also this project itself has been included in an initiative that we run in the city, which is the local awareness and early diagnosis, and that's initiative, and that's a high level meeting with stakeholders, and we look at what's going on, how we can improve things, and this has gone into their plan, which is actually quite a bonus, and we're actually really proud of managing to do that. So Taha is now going to talk around the actual intervention as it ended up.
Thank you, Julie. Right, you have heard now the two, what we did and now what we are intending to do. So if we are lucky, we summarized those people that we are going to work with in our new project. Three key strategic areas that we need to consider in everything that we do. So to consider, it's with bowel cancer mainly directly involves the national hub. When somebody is 60, he or she will get a letter inviting them for a test. So that's the national hub will send that letter straight away. And a copy, if I'm right, Daniel, a copy will go to the practice. So the three areas will know about what's happening, nobody else. So these are the three key areas that we need to consider. We have worked, as you have heard from Jahanara, we have some ideas about patients and public engagement. We know now quite a lot about practices. We know very little now about the national hub, but I'm very pleased Daniel is here. And it is Daniel who suggested that we do a presentation to the next board meeting. Maybe that's an opportunity to explain to them what we have done so far. So if that happens, that will be, we have a number of requests or wish lists. We may get 1%, 5%, 10%, but we have a wish list. So we'll see. So what will the intervention about? We are planning, as Richard indicated, there is a big problem, and we want to increase bowel cancer screening uptake in those three areas where there is a big population of BAME communities. So that's what we want to do. So how we want to do it, first of all, at the moment, the Liverpool City Council Public Health is the lead for this project, and we have submitted the business case, and I'm waiting for their approval. So that's the first thing that we wait for. Then, As you all know, that we have some serious issues about funding and the public health funding cuts and so on and so forth. So we have to think creatively how to get this money to fund this project. And we know how much it's going to cost based on what Julie referred to, the conference we had with Tower Hamlet. So that's roughly the sum that you need to consider. We have some ideas about what this GB specification is going to be. So we have to negotiate, and we will start, with those who are willing to be with us. One thing that we learned, that if you are going to commission an organization, it has to be an organization with a track record, and this is from the Tower Hamlet learning point. So there is no point of commissioning an organization that does not have track record in working in this area. I've mentioned, what we expect from the National Hub. In our intervention, we think the most effective way is to have somebody who will do the search in the practice, and then when he or she will call the patients, especially those who do not attend. So that's what we are planning to do. And then we are introducing something because many people are now using mobile phones, so we think maybe SMS will be a way forward. Believe it or not, this is true. Richard mentioned the last 18 months, and one of the things we want to improve patient records, both ethnicity and language. And I have been talking to numerous people about how can we get this right, and that's why Julie said patient profiling is back on the table. I just wanted to have a sense, how difficult or easy it is going to be. Yesterday, this is after 18 months waiting, yesterday I got an email, very quick email. It takes seconds to put an alert in the system so that when somebody does not speak English or have poor English, it can pop up. Or if somebody is not recorded his or her ethnicity, it's very easy to do. Now, I have been told many different stories. It's difficult, takes time, and so on and so forth. And it is so crucial in our communication, especially between patient as well as his or her GP. So we're learning, and I think, thank goodness, we were part of Clark, and we are learning every day. Whatever we decide to do, we have to get the approval of the local medical council, and we want to engage the academia with us so that the evaluation will be crucial. Again, the engagement of BAME was really, really valuable, and we will keep it that way. How to continue with Clark, I really don't know. Maybe we have some ideas, but we will explore it, this afternoon. So, in summary, Juliet said that we have learned individually, as a team, and cross-organization. That has been extremely valuable. Our GP, who is so keen and enthusiastic, who you saw with the clip, he was unable to come today. He now just a new person talking about multidisciplinary work. That's the only way. He's a GP, by the way. So he has been converted to work in a multidisciplinary team. Wow, this is great. We know there's going to be a lot of challenges, but I think we are confident that we have learned a great deal, and we are able to, our resilience is stronger, so we'll be able to bounce again rather than falling. The information, if we can get that right, that will be a big bonus. That's all I want to say. So thank you for listening. And if there is any question, here is the team. By the way, the team, just only part of the team is here. It is a big team, really big team. And I'm very proud of the team who has been very committed, worked very hard, despite all additional workers. Every time I send an email, request this, request that, the commitment has been enormous. Thank you very much.
Well, I think the teams have done a stunning job. They've done all of the things that we asked them to do. The history of the Clark is that it has to do with health inequalities and there has to be public engagement, and that's happened across the themes. It's identified some challenges in all of that, but actually it has all grown. The teams have done things like patient and public involvement in different ways. We can't judge that as successful or not successful. It worked for their teams and worked very well for their teams. So it's really contributed to the work of the Clark in terms of looking at health inequalities, patient engagement, and changing practice to improve the population's health.